Hello guys, welcome to this MCQ discussion. I'm going to quickly discuss 10 MCQs at probably an SS level, and we'll be trying to finish off all these MCQs in a span of 10 to 15 minutes. Let us go into the session. This is question number 1. This image represents which of the following? As you can see the image, something is wrong with the thoracic aorta for sure. At the same time, you can see that the calcium is actually displaced towards the lumen. So this displacement of the calcium towards the lumen says something is wrong in the aortic wall. That is also confirmed by thickening of the aortic wall. So it must be either a probable dissection or it must be an intramural hematoma. Or in a rare event, it could be even a penetrating atherosclerotic ulcer. But it's not a penetrating atherosclerotic ulcer because in a penetrating atherosclerotic ulcer, your contrast will be slightly extravasating into the vessel wall and there will be a clear-cut neck of that ulcer. So that is not visible here. So that possibility is not there. So it must be either a dissection or an intramural hematoma. So it is very likely to be an intramural hematoma because in an intramural hematoma, you don't have the communication of the lumen with the vessel wall. Because you don't have the communication of the lumen with the vessel wall, your contrast typically does not enter the vessel wall at all. Whereas in aortic dissection, you're going to have a clear-cut communication with the lumen and the vessel wall. So you will be definitely having that extravasation of the contrast into the false lumen, that is into the vessel wall. So that is not the case here. So this is definitely an intramural hematoma. Even in transesophageal echo, you will be able to demonstrate that moving intimal flap, plus at the same time you can establish the flow in the color Doppler between the true lumen and the false lumen if it's an aortic dissection, but that will not be the case in the setting of an intramural hematoma. Remember, intramural hematoma as well as dissection will be treated in the same manner. There is not much of a difference in the classification as well as management. Let us move on to the question number 2. Here is your 82-year-old female presents to emergency with complaints of nausea and vomiting and general fatigue. She complains of seeing yellow ring around light bulbs and nearby objects. She reports taking some heart pills, but she doesn't know the name of the medication. ECG shows marked sinus bradycardia with a rate of 33 beats per minute and BP is slightly on the lower side, maybe in a kind of a compensated shock at 88/59 millimeters of mercury. What is the next step in the management? So as the question implies, it's clearly a case of digitalis toxicity. There is absolutely no doubt about that. In fact, one of the first and earliest signs of digitalis toxicity is nausea and vomiting plus or minus a generalized fatigue. And here they are given a classic history of xanthochromia. That yellowish discoloration of the vision is very classic and it's been given in this question as well. And ECG showing marked sinus bradycardia. In fact, bradyarrhythmia is one of the commonest complication of digitalis toxicity because digitalis is something that has a vagomimetic effect and it can produce variety of AV blocks. Generally, it doesn't produce Mobitz type 2. In fact, it can produce any bradyarrhythmias and any AV block except Mobitz type 2. So this patient is having a sinus bradycardia. So definitely, so you need to treat accordingly, and the appropriate treatment in this situation is going to be administering a binding antibody that is called as digibind. So lignocaine may be an option in emergency case of digitalis toxicity with ventricular tachyarrhythmias, especially VTs. Before giving digibind, you can try lignocaine in that situation. Administer activated charcoal. So we don't really do that if the patient presents beyond 6 hours. It's not going to be that effective. And stop home medication and observe is also not going to be an appropriate management in this situation because the patient is having a clear-cut bradyarrhythmia that is causing hemodynamic compromise. Now going to question number 3. Which of the following statements about Brugada syndrome is true? So the disease is more prevalent in females than males. That is a false statement because the disease is 9 times more prevalent in males compared to that of females. And one more interesting thing is the fact that schizophrenia patients have a higher incidence of showing Brugada pattern. We don't know the specific reason for that. And the most commonly associated genetic mutation is SCN10A. This is also a false statement. Remember, SCN10A mutations are actually indeed associated with Brugada syndrome, but it is not the most common mutation. SCN5A is the most common mutation. The primary treatment is radio frequency catheter ablation is also a false statement because the primary treatment is actually ICD implantation, that is implantable cardioverter defibrillator and not RFA, even though some newer studies say that RFA is also an effective treatment option, but definitely is not going to be the first line treatment option. And the typical EKG shows a code type ST segment elevation of more than or equal to 2 mm, followed by a negative T wave of more than or equal to 1 mm in the right precordial leads, that is V1 and V2. This is absolutely a true statement. And in fact, what they have given is the diagnostic criteria for a type 1 Brugada pattern, which is the most common pattern, to be honest. And many drugs, including 1A, 1C, antiarrhythmics, even SSRIs, TCS, can also bring out the Brugada pattern in the EKG in certain susceptible individuals. And this Brugada pattern alone will not constitute the Brugada syndrome. If the patient is having symptoms or probably a family history, then that can be probably called as Brugada syndrome. We all know that Brugada syndrome can be associated with sodium channel mutations, which is the most common, and it can be associated with calcium channel mutations also. Among the sodium channel mutations, the SCN5A mutations are going to be the most common. And this typical type 1 pattern of Brugada syndrome is what we called as the pseudo right bundle branch block with ST elevation and a code pattern with a little bit of T wave inversion. This is classically seen in V1 and V2. So the right answer for this question is going to be option number D. And here is your question number 4. A 47-year-old construction worker who sustained a crush injury at work 4 months prior is admitted to your service with a foot ulcer. On examination, there is an open ulcer in the lateral part of the foot with necrotic edges, basal erythema and foul smell. Pus is actually draining from the ulcer. You have done an MRI which revealed changes that are concerning for osteomyelitis of the fifth metatarsal. A bone biopsy was done on admission and results are pending. Cultures are in progress. Lab results are as follows. WBC is mildly elevated. ESR is around 128 millimeters and CRP is around 54 milligrams per liter. And which empirical antibiotics is indicated at this time. Remember, whenever you have a case of osteomyelitis, you need to give two important coverage. One is MRSA coverage, and of course the second one is going to be a gram-negative bacilli coverage, or you can call it as a gram-negative rods cover. So usually this gram-negative rods cover is given with the help of ceftriaxone, which covers a lot of gram-negative organisms, and MRSA cover will be typically given with vancomycin. Here the right answer is going to be D. Why the other answers are wrong? For example, oxacillin plus ceftriaxone is wrong because oxacillin gives an excellent MSSA coverage, but it's not going to give an MRSA cover. Vancomycin and piperazine tazobactam is also wrong, even though piptaz can give a good amount of GNB cover, but still this combination of vancomycin and piptaz is generally thought to be highly nephrotoxic and should be avoided in practice as much as possible. And this is confirmed in many trials, including the one of the recent Merino trials, which said that meropenem is superior to piptaz in patients with septic shock, especially if you are having suspicion of resistant organisms. In that trial also, they proved that piptaz and vancomycin combination is not going to be that appropriate because of the risk of nephrotoxicity. And vancomycin plus ciproflox is not an appropriate combination as well, because almost if you see 30% of the Indians generally have some sort of quinolone resistance, so that's not going to be a very appropriate option as well. So the right answer for this question is option number D. And coming to question number 5, which of the following statements is true regarding anti-reflux surgery? The option number A says anti-reflux surgery will eliminate the risk of esophageal cancer. This is an absolutely false statement, because PPIs and anti-reflux surgeries can reduce the symptoms of GRD, but it's not going to eliminate the risk of your esophageal cancer if the patient is having Barrett's esophagus. So that is why the treatment of Barrett's is either going to be endoscopic surveillance, or you need to treat if it's a high-grade dysplasia. There is no role for PPIs or your anti-reflux surgeries, which is going to cause regression of the Barrett's mucosa or eliminate the risk of esophageal cancer. That's a false statement. Anti-reflux surgery has been shown to improve symptoms in patients with regurgitation. That's what I've been talking about. It's a very true statement. So the right answer for this question is going to be option number B. And endoluminal, that is endoscopic anti-reflux procedures are as effective as anti-reflux surgery without the associated complications of surgery is also a false statement, because endoscopic or endoluminal surgeries are not that effective as anti-reflux procedures. In fact, people who go for endoscopic procedures generally get symptoms, recurrence of these symptoms by around 3 to 5 years mark, and most of the patients will be needing high dose PPI or probably even an anti-reflux surgery by around 3 to 5 years mark. So that's why it's not an effective option compared to anti-reflux surgery. And anti-reflux surgeries can be effective option in the setting of metaplasia or dysplasia of on endoscopy is also very false statement, because whenever the patient is having metaplasia or dysplasia with Barrett's esophagus, the right treatment option is going to be therapy of that metaplasia or dysplasia, or you can go for frequent endoscopic surveillance. In fact, if you have a metaplasia or dysplasia, your anti-reflux surgeries should be avoided, because later on, when you develop cancer, if you do an anti-reflux surgery prior, it might be tricky to do surgeries. So that area might be distorted, and it is not appropriate to do anti-reflux surgery in the presence of metaplasia or dysplasia because of the concerning change in the anatomy because of anti-reflux surgeries if the patient goes for future esophageal cancer. That is why that is also a false statement. The right answer for this question is going to be option number B. And coming to question number 6, a patient with autoimmune hepatitis is undergoing liver transplantation for decompensated cirrhosis. Which of the following is true? Matching of HLA alleles between donor and recipient has been demonstrated to reduce the risk of recurrence of autoimmune hepatitis less than 5%. Is a false statement. In fact, before any liver transplantation, we don't really do HLA matching, and HLA matching has not shown any extra advantage except for small series and small trials. Generally, it is not done. In fact, HLA-A and HLA-DR matching has been associated with reduced survival in patients with liver transplant. So, it is not done generally, and there is no association between HLA matching and reduced recurrence of autoimmune hepatitis. And the median time for development of recurrent autoimmune hepatitis 5 years after liver transplantation is also a false statement. It's approximately around 2 years, or maybe around 2 to 3 years, not 5 years. And corticosteroids are ineffective in the treatment of AH recurrence in the allograft is also a false statement, because corticosteroids along with probably azathioprine are going to be effective treatment option for autoimmune hepatitis and its recurrence in the allograft. And compared to patients with other etiologies of liver disease, patients with autoimmune hepatitis have a higher frequency of acute and chronic resistance. This is an absolutely true statement. So compared to other causes because of which you are doing liver transplantation, if you are doing liver transplantation for autoimmune hepatitis, there is definitely a high risk of rejection, both acute as well as chronic rejection. So the right answer for this question is going to be option number D. And coming to question number 7, a 73-year-old male undergoes surveillance MRI of a side branch lesion in the uncinate process discovered incidentally 2 years earlier on CT scan. At that time, fine needle aspiration revealed benign cytology. The patient had a CA level of around 840. So whenever you have a cystic neoplasm of the pancreas, and if the CA levels are elevated, often indicates a mucinous tumor, because it's involving a side branch, which means it's involving a duct. So this must be a intrapapillary mucinous neoplasm. So which arises from the duct. So it's not arising from the main duct. So it's arising from the side branch. So today the lesion is 3.5 centimeter with a 5 millimeter mural nodule. Which of the following is indicated in the management of this patient? Because repeat MRI in 6 months is an inappropriate option, because first of all, let me tell you the indications for surgery. So whenever the patient is having involvement of the main pancreatic duct and an IPMN, so generally surgery is indicated. Or if the patient is having involvement of the branch duct, in this situation, if the lesion, the cystic lesion is more than 3 centimeter, that is 30 millimeter, or if the presence of a mural nodule is confirmed, non-enhancing mural nodule is confirmed, especially if the nodule is more than 10 millimeter, but just the presence of mural nodule is enough according to most guidelines. But if it's more than 10 millimeter, then these are going to be definite indications for surgery, because this indicate the high risk of malignancy. And apart from that, if the patient is coming with other complications like pancreatitis, or the patient is having exocrine pancreatic insufficiency, so these are all becomes indication for surgery of the tumor. So repeating MRI in 6 months is not optimal, because the lesion size is more than 3 centimeter and surgery is going to be warranted. So repeating USFNA is not warranted in this situation, because that is not going to alter the management, because this patient already underwent an FNA and clearly proved that's a benign neoplasm, and right now doing a USFNA is not going to give you any additional advantage. And octreoscan is absolutely useless in any cystic neoplasm. Maybe it might be useful in a pancreatic neuroendocrine tumor, but it's not going to be helpful here at all. And surgical resection is the best treatment for this particular individual, because the lesion is more than 3.5 centimeter. More than 3 centimeter, which indicates the risk of malignancy. And question number 8, a 40-year-old man presents to your clinic with PMH of muscle weakness and hypokalemia. There is no family history of muscle weakness with hypokalemia. Physical examination is significant for blood pressure of 150/90. So patient is hypertensive and patient is tachycardic with a heart rate of approximately 110 beats per minute and a respiratory rate of 18 beats per minute, which is normal. The patient also has an enlarged thyroid and a 6 kg of unintended weight loss in the previous month. Which of the following is the most likely diagnosis? Because this patient is not having a typical family history, I will definitely rule out an inherited cause. And diuretic use is not going to result in hypertension and tachycardia, and enlarged thyroid, weight loss and all is not explained by diuretic use. And Conn syndrome can explain the high blood pressure, but it's not going to explain the tachycardia and the weight loss typically. So the only diagnosis out of exclusion is going to be acquired hypokalemic periodic paralysis, because here we suspect hyperthyroidism and thyrotoxicosis. And because of the same, patient has gone for hypokalemia, because hyperthyroidism is one of the important cause of hypokalemia, because thyroid hormone is known to activate the efficacy of catecholamines. It's going to increase the efficacy of catecholamines, which can indirectly activate the sodium potassium ATPase, which can result in significant transcellular movement of potassium from outside the cell to inside the cell, which can result in significant hypokalemia. And it can result in hypokalemic periodic paralysis. Of course, because it's due to thyrotoxicosis, it must be acquired in nature. So the right answer for this question is going to be acquired hypokalemic periodic paralysis. And going to the question number 9, a patient with hypertensive encephalopathy and blood pressure of 200/130 millimeters of mercury is treated with an intravenous infusion of sodium nitroprusside. Which of the following statement is correct concerning this medication? Sodium nitroprusside increases cerebral perfusion pressure is a wrong statement. Why it is the wrong statement? Because sodium nitroprusside tends to cause severe cerebral vasodilatation. Because it produces cerebral vasodilation, it increases the cerebral blood flow. Because it increases the cerebral blood flow, it increases the cerebral blood volume. And because it increases the cerebral blood volume, it is going to increase the intracranial pressure. Please understand, your cerebral perfusion pressure is going to be the difference between mean arterial pressure and intracranial pressure. And sodium nitroprusside is something that produces systemic peripheral vasodilation also, which definitely is going to reduce the mean arterial pressure because of vasodilatation. Because your MAP is decreasing and your ICP is increasing, your CPP is going to decrease. So it is something that can reduce the cerebral perfusion pressure. So option number 1 is false. And that is also one reason why sodium nitroprusside should not be used in patients with intracranial hemorrhage, because intracranial hemorrhage patients will already have raised ICP and low CPP, and giving sodium nitroprusside can worsen this hemodynamics, so that you should avoid sodium nitroprusside in patients who are suffering from intracranial hemorrhage. And sodium nitroprusside results in venodilation, not in arterial vasodilation. This is a false statement as well, because sodium nitroprusside is a primary arteriolar vasodilator, whereas your nitroglycerin probably is a primary venodilator than arteriolar vasodilator, but sodium nitroprusside is a primary arteriolar vasodilator compared to venodilator. And sodium nitroprusside has negative inotropic effect. No, it doesn't have any effect on the inotropic potential of the heart. So this is also a false statement. And metabolism of sodium nitroprusside results in production of nitric oxide and cyanide. So this is a true statement. That is why high dose infusions of sodium nitroprusside or long-term infusion of sodium nitroprusside can be typically associated with cyanide toxicity. How will you suspect whenever a patient goes for probably altered mental status and lactic acidosis in the event of a normal PaO to normal saturation? In the context of a patient who is receiving a high dose sodium nitroprusside, you can always almost suspect a cyanide toxicity. So the right answer for this question is going to be option number D. And last question, a 27-year-old woman with history of migraines and depression presents with a severe headache that started a few hours ago. Patient states that while having breakfast, she experienced a sudden onset 10 out of 10 headache, which means the headache reached its maximum intensity within a very short span of time. So it must be a thunderclap headache that felt different from a regular migraines, which means it's a kind of a new onset severe headache, which is very different from her usual headache. She felt nauseated but did not vomit. Her home medications include escitalopram, which is basically an SSRI medication for depression. CT of her head shows a small convexity subarachnoid hemorrhage. This is a very useful point again, because that convexity subarachnoid hemorrhages are classical for one particular disease. We will see what is that, involving the post-central sulcus on the right near the parietal lobe, of course. And perfusion-weighted MRI is significant for hypoperfusion in the watershed regions. The patient's neurological examination is unremarkable, but she does not tolerate a bedside fundoscopic examination because of photophobia. That may be due to meningeal irritation because of subarachnoid hemorrhage. And what is the most likely diagnosis? This patient is having all the classic features of RCVS, that is reversible cerebral vasoconstriction syndrome. Usually there will be a trigger, there will be a precipitating problem in a patient with RCVS. Generally, it will be either a migraine in exam. Migraine is associated in almost 30 to 40% of the individuals because migraine is also a vascular disorder. And patient may have some history of exposure to drugs. The most important are going to be SSRIs and some recreational drugs like marijuana. So in this situation, the patient is having history of SSRI intake for depression. And at the same time, patients will commonly present with a thunderclap headache. Because the patient presents with thunderclap headache, you generally tend to think it in terms of a subarachnoid hemorrhage. And if you do a CT or an MRI, so you are going to see that classic convexity subarachnoid hemorrhage. That is again a very classic feature of a RCVS, reversible cerebral vasoconstriction syndrome. And apart from that, how can you diagnose further? If you do a perfusion weighted imaging, in this situation, you can see hypoperfusion in the watershed areas. Why? Because this is not a thromboembolic disease, rather this is a kind of a vasoconstriction that is happening. So the distal-most areas, the watershed areas, the overlapping vascular territories, these are the areas that are commonly affected because they are the distal-most areas. And in traditional angiogram, especially in digital subtraction angiography or probably even in CT or MR angiography, you are going to see alternating constrictions and bleeding. Certain proximal vessels will be constricted and some second and third order vessels may be dilated. So this alternating constriction dilatations is what we call as bleeding, and that is something that can be seen in patients with RCVS. Even though it's not a very specific sign for RCVS, but it's still very commonly seen in patients with RCVS and you can demonstrate it. And FLAIR MRI or probably a diffusion-weighted sequencing of MRI can show a focal area of cerebral hypoperfusion and ischemia, and that is what we refer to as the famous dot sign. So this is another feature of RCVS. So right answer for this question is going to be RCVS. It's not aneurysmal subarachnoid hemorrhage, even though aneurysmal subarachnoid hemorrhage can produce thunderclap headache and it can also produce vasoconstriction, but the features that is given here are very classic of RCVS rather than aneurysmal subarachnoid hemorrhage. Usually aneurysmal subarachnoid hemorrhage will be associated with Valsalva response when you are lifting heavy weight, or when you are stressed, or when you are hypertensive. So that time you can suspect, or probably this patient will be having a diffuse vasoconstriction rather than this kind of beaded appearance of the vessels. And dural AV fistula usually develops as a complication of a cerebral venous thrombosis, CVT, and usually they will not produce that classic convexity subarachnoid hemorrhage, and most of the time they will be having associated subdural hemorrhage, which is not the case in this case scenario. And superior sagittal sinus thrombosis, on the other hand, will produce different set of signs, and they can also sometimes come with thunderclap headache, but generally they will be having history of some subacute headache ongoing for certain days to weeks. So that is not the case here, and generally they can also be associated with a small amount of subarachnoid hemorrhage, but they will be having a different set of MRI and imaging signs, and they'll be having a different set of fundoscopic picture, and they'll commonly show papilledema. So that's a completely different diagnosis. That is, the diagnostic features of cortical thrombosis are not fitting into this case scenario, and the only diagnosis that clearly fits into this case scenario is RCVS. Hence, that is going to be the diagnosis. And I think in a short span of time, I've completed all the 10 questions with a decent amount of explanation. Hope you enjoyed the session, and let me see you in all the next session.